Why healthy people have heart attacks. Prevention tips. A person can maintain peak physical condition, effortlessly completing a demanding 10K race, experiencing no discernible symptoms of illness or fatigue, and radiating an undeniable sense of vitality and robust health. Yet, simultaneously, within the intricate and vital network of their cardiovascular system, a perilous widowmaker blockage could be insidiously developing, silently progressing towards a critical and life-threatening state. The profound question arises: how is such a deceptive internal threat biologically possible in an outwardly healthy individual? The answer lies in the astonishing, yet sometimes treacherous, adaptability of human biology. Your body possesses an unparalleled capacity for compensation and resilience. It does not prioritize athletic prowess or external fitness metrics over internal physiological balance. This remarkable adaptive capability means it can effectively mask a significant obstruction, potentially a 90% blockage in a major coronary artery, by subtly altering blood flow dynamics and maintaining near-perfect circulation. This delicate balance persists, often entirely undetected, right up until the critical moment when this compensatory mechanism fails and blood flow abruptly ceases. This alarming reality explains why, for a staggering half of all men and an even higher percentage of women, the very first manifestation of severe heart disease is not a gradual onset of pain, shortness of breath, or any other warning sign, but rather the sudden and catastrophic event of cardiac arrest and immediate death. It is a cruel irony that the body's sophisticated protective mechanisms can, in certain circumstances, become its greatest deceivers. To truly grasp why even a seemingly healthy engine like the human heart can abruptly fail, we must undertake a journey into its fundamental structure and function. Peeling back the metaphorical chest wall, we observe the heart as an extraordinary muscular organ, tirelessly pumping blood throughout the body. This muscle, however, is unique in its relentless demands, requiring more oxygen and nutrients than almost any other tissue in the human anatomy. To meet this insatiable demand, the heart itself is enveloped by an intricate, life-sustaining network of specialized blood vessels, known as the coronary arteries. Early anatomists, struck by their appearance, perceived these vessels as a crown encircling the heart, thus bestowing upon them the term coronary from the Latin corona. However, a more intuitive and perhaps more illustrative analogy is to envision these arteries as the sophisticated root system of a massive, vital tree. Just as a tree's branches wither and die if their nourishing roots are severed, so too does a section of heart muscle perish almost instantly if its supplying coronary artery is occluded, deprived of its essential lifeblood. Within this intricate root system, two primary arteries dominate: the right coronary artery and the left coronary artery. The left coronary artery quickly bifurcates into a number of significant branches, with one particularly large and critically important vessel known as the left anterior descending artery, or LAD. In the urgent environment of the emergency room, medical professionals have a stark and chilling nickname for this specific artery: the Widowmaker. The rationale behind this grim appellation lies in simple yet devastating cardiac geometry. The LAD artery is responsible for supplying a vast expanse of blood to the front and bottom sections of the left ventricle, which serves as the heart's primary and most powerful pumping chamber. Analogously, if a small twig on a tree is broken, only a single leaf might be lost. But if the main trunk of the tree is severed, the entire tree inevitably collapses. A severe or complete blockage within the LAD artery profoundly impairs the heart's ability to effectively pump blood to the rest of the body, leading to massive, irreversible tissue death in the affected myocardial region. This often results in immediate cardiac arrest and a high mortality rate, underlining the critical importance of this particular vessel. The critical question then arises: how does such a lethal blockage materialize within the artery arteries of an individual who meticulously maintains a rigorous exercise regimen and appears to embody perfect health. To unravel this mystery, we must zoom in on the microscopic structure of the arterial vessel wall itself. A healthy artery is not rigid. It possesses remarkable elasticity and flexibility, akin to a brand new rubber garden hose, supple, resilient, and unobstructed. The innermost lining of this artery is called the tunica intima, a delicate and vital layer of endothelial cells. In an ideal physiological state, this lining is extraordinarily smooth, almost like Teflon, allowing blood cells to glide past with minimal friction, ensuring unimpeded flow. However, the realities of human life are far from perfect. Over a span of decades, various detrimental factors begin to exert their cumulative toll, acting like persistent sandpaper, abrading this pristine endothelial coating. Chronic high blood pressure, for instance, subjects the arterial walls to excessive mechanical stress, causing microscopic shear forces that can damage endothelial cells. Elevated blood sugar levels, common in prediabetes and diabetes, contribute to glycation processes and oxidative stress, directly injuring the delicate endothelial lining. Smoking introduces a barrage of toxins and free radicals that directly compromise endothelial integrity. Even the sustained shear mechanical stress associated with high-volume blood flow during decades of intense physical exercise, while otherwise profoundly beneficial for overall health, can paradoxically contribute to microscopic scratches and subtle tears in this delicate inner lining, setting the stage for future problems. This is precisely where the insidious trouble begins. Your body, ever the diligent repair mechanism, immediately initiates efforts to mend these microscopic injuries. It dispatches low-density lipoprotein (LDL) cholesterol, often colloquially termed bad cholesterol, to the damaged sites. Imagine LDL acting like a biological spackle, sent to patch up the minute abrasions and tears in the arterial wall. Subsequently, the body's immune system, recognizing the site of injury and the accumulating LDL particles, mobilizes white blood cells, specifically monocytes, which infiltrate the damaged arterial wall. These monocytes then transform into macrophages, which avidly consume the excess LDL cholesterol, attempting to clear the debris. As they become engorged with cholesterol, they take on a foamy appearance and are thus termed foam cells. Over time, this complex mixture of cholesterol, calcium deposits, which contribute to the hardening and calcification visible on scans, cellular debris, inflammatory cells, and fibrous tissue, undergoes a profound transformation, gradually hardening and accumulating within the arterial wall. This hardened, calcified, and inflammatory material is what we medically define as atherosclerotic plaque. The progressive buildup of these plaques within the arteries is the hallmark of a chronic inflammatory condition known as atherosclerosis. This process is not a sudden event, but a slow, decades-long progression, often without any outward signs. Herein lies a critical misconception that tragically leads many individuals to a fatal outcome. The popular imagination often visualizes plaque buildup as a simple, mechanical clog in a household plumbing system, much like a drain slowly narrowing in a bathroom sink due to accumulated hair and grime. People erroneously believe that the arterial pipe gradually constricts, becoming progressively narrower and narrower until, one fateful day, the flow of blood simply stops. This intuitive, yet fundamentally flawed understanding leads to the assumption that they will inevitably experience unmistakable warning signs, perhaps increasing shortness of breath, a persistent discomfort, or characteristic chest pain, as the arterial opening progressively diminishes. While this line of reasoning might appear logically sound from an engineering perspective, it is profoundly incorrect when viewed through the intricate lens of human biology. The heart's internal mechanisms are far more sophisticated and paradoxically far more deceptive. The human body is an astonishingly adaptive biological machine. As atherosclerotic plaque slowly and insidiously accumulates and expands within the artery wall, the vessel does not simply constrict inward, as one might expect from a clogged pipe. Instead, in a phenomenon known as positive remodeling, the artery wall itself actively stretches outward. This sophisticated compensatory mechanism works to accommodate the growing plaque burden, effectively preserving the internal lumen or opening through which blood flows. This means that an individual can harbor a substantial, even massive, amount of atherosclerotic plaque within their coronary arteries, yet the internal channel itself can remain remarkably 100% open, maintaining an outwardly normal diameter. Consequently, blood flow continues unimpeded and perfectly normal, and the individual experiences absolutely zero symptoms. They can effortlessly complete a challenging 10K run, feeling absolutely fantastic, precisely because the essential blood supply is still navigating its path through an outwardly pristine yet internally compromised vessel. This extraordinary yet ultimately deceptive biological adaptation is why for 50% of men and an even higher 64% of women, the very first indication of underlying heart disease is not a subtle twinge or a persistent ache, but rather the sudden and utterly unexpected cessation of life itself. They genuinely feel perfectly well and entirely healthy right up until the critical second when their life-sustaining circulation abruptly and irrevocably fails. So, what is the precipitating factor that abruptly flips the switch, transforming a silently lurking plaque into a catastrophic, life-threatening event? The answer lies in the concept of plaque stability. Envision that developing plaque deposit not as a solid, immutable mass, but rather as something akin to a fragile blister, its volatile contents contained beneath a thin, delicate layer of skin. This soft plaque is particularly dangerous because it is rich in a necrotic core of inflammatory cells, lipids, and cellular debris, a highly thrombogenic gunk. If an individual experiences a sudden and dramatic spike in blood pressure, perhaps due to acute emotional stress, or engages in an episode of extreme physical exertion that places immense shear strain on the arterial walls, that tenuous, thin, fibrous cap covering the soft plaque can tragically tear or rupture. This event is medically known as a plaque rupture. When that unstable plaque ruptures, its highly inflammatory and procoagulant contents are suddenly exposed and spilled directly into the bloodstream. The body's sophisticated biological defense system, perceiving this internal exposure as a massive, open wound requiring immediate sealing, reacts with alarming speed and efficiency. It swiftly dispatches platelets, tiny, disc-shaped blood cells crucial for initiating clotting, to the site of injury. While this rapid aggregation of platelets is precisely what is needed to staunch blood flow if you accidentally cut your finger, it is the absolute last thing you desire to occur inside the vital arteries supplying your heart. In a terrifyingly short span of mere minutes, this initial platelet plug rapidly escalates. The coagulation cascade, a complex series of enzymatic reactions, is activated, leading to the formation of a robust fibrin mesh that traps red blood cells and more platelets, creating a rapidly expanding thrombus, or blood clot. This clot grows so substantially and so quickly that it completely occludes or seals off the artery. The fundamental cause of the myocardial infarction, heart attack, is not the gradual, slow buildup of plaque that eventually clogged the flow. Rather, it is the sudden, explosive, and rapid formation of this obstructive blood clot. It acts with the finality of a cork abruptly jammed into the neck of a wine bottle, instantaneously bringing blood flow to a complete and devastating brick wall. This acute event is medically classified as a type 1 myocardial infarction, a heart attack directly caused by plaque rupture and subsequent thrombus formation, often leading to sudden cardiac death. However, there exists another critical scenario that frequently impacts individuals, particularly endurance athletes who consistently push their physical limits: the type 2 myocardial infarction. Consider the illustrative case of Robert, a dedicated and disciplined 50-year-old runner who maintains normal cholesterol levels. While participating in a demanding road race, Robert doesn't experience the stereotypical crushing chest pain often depicted in media. Instead, he simply feels weird, an unsettling sensation of profound energy drop accompanied by lightheadedness and nausea. Attributing these vague symptoms to simple dehydration or fatigue, he attempts to push through. Upon arriving at the hospital, doctors quickly identify the presence of a protein called troponin in his bloodstream. To conceptualize troponin, one can think of it as the luminescent liquid contained within a glow stick. As long as the stick's plastic casing remains intact, the luminescent liquid stays securely inside. But if you bend or snap the stick, the casing ruptures and the liquid leaks out. Similarly, heart muscle cells are replete with troponin. If these cells are damaged and die, their structural integrity is compromised, causing troponin to leak out into the bloodstream, where it becomes a quantifiable and highly sensitive biomarker of cardiac injury. Robert is indeed experiencing a heart attack, yet when cardiologists examine his coronary arteries through angiography, they don't discover a completely blocked vessel. Instead, they find a moderate, perhaps 50% blockage. This raises a crucial question: how could he be having a heart attack with blood still flowing through his artery? The explanation lies in a fundamental principle of cardiac physiology, a critical supply and demand problem. While Robert is resting calmly on a couch, a 50% blockage is largely irrelevant. The hose might be slightly crimped, but sufficient water, blood, still gets through to water the grass, meet the heart's resting metabolic demands. However, when Robert's heart rate surges to 170 beats per minute during intense exercise, his working heart muscle demands an enormous volume of oxygenated blood, akin to needing a fire hose worth of supply. The partially crimped artery, restricted by its 50% blockage, can only deliver a fraction of that demand, perhaps merely a garden hose worth. Under these strenuous conditions, the heart's demand for oxygenated blood dramatically outstrips the compromised artery's ability to supply it. The heart muscle, deprived of adequate oxygen, begins to suffer and literally suffocate at a cellular level. This condition is medically termed ischemia. This scenario of demand-induced ischemia leading to myocardial injury is characteristic of a type 2 myocardial infarction. In Robert's specific case, an additional complicating factor was identified: atrial fibrillation, or AFib. The heart operates on a precise and finely tuned electrical grid, which orchestrates a coordinated, rhythmic squeeze of its chambers, ensuring efficient blood pumping. In AFib, the heart's upper chambers, atria, cease their organized, effective contraction, and instead begin to quiver erratically and inefficiently. This chaotic electrical activity severely disrupts the heart's natural rhythm and timing. The ventricles, the main pumping chambers, then beat rapidly and irregularly. When you combine a pre-existing partial blockage, which inherently reduces the maximum possible blood supply to the heart muscle, with the rapid and often irregular heartbeat characteristic of AFib, which drastically increases the heart's oxygen demand and simultaneously reduces the time available for the ventricles to fill with blood, you create a truly perfect storm scenario. The heart is beating so rapidly that its chambers do not have sufficient time to fully fill with blood, further compromising cardiac output. Simultaneously, the compromised coronary arteries are unable to deliver the necessary oxygen to sustain such an accelerated pace. The cumulative effect is profound ischemia and myocardial injury, exemplifying the devastating consequences of an imbalanced supply-demand ratio. These scenarios highlight an important clinical threshold. Generally, individuals will not experience noticeable chest pain, medically termed angina, until a coronary artery is approximately 70% blocked. Below this critical threshold, the heart's remarkable compensatory mechanisms are often sufficient to maintain adequate blood flow, even under moderate stress, preventing overt symptoms. However, once the blockage exceeds this 70% mark, the compensatory capacity is overwhelmed. At this point, you might begin to feel a distinct tightness, pressure, or discomfort in your chest when engaging in activities that increase cardiac demand, such as walking briskly upstairs, carrying heavy groceries, or ascending a steep incline. Crucially, this discomfort typically subsides when you rest, and the heart's demand lessens. This symptom is known as stable angina, and it represents your body's check engine light, a clear warning signal that your coronary arteries are significantly compromised and that the heart Muscle is experiencing demand-induced ischemia. Yet, it is vital to remember that the majority of truly fatal heart attacks do not occur in individuals with these large, stable, 70% plus blockages that cause classic angina. Paradoxically, most heart attacks, particularly type 1 MIs, occur in people with less than 50% blockage. This is because it is the soft plaques, the smaller, unstable, lipid-rich, and inflammatory lesions with thin, fibrous caps that are far more prone to rupture and subsequent thrombus formation than the larger, often more calcified and stable plaques that cause classic angina. This critical distinction underscores the danger of relying solely on symptoms for detection. So, if symptoms are often absent until it's too late, and even when present can be misleading, is there any silver lining or a hidden advantage within our biological design? Indeed, the heart possesses a remarkable secret backup system known as collateral circulation. Imagine your main coronary arteries as major interstate highways, efficiently transporting vast amounts of blood. If a significant traffic jam or blockage persists in one of these main arteries for an extended period, perhaps over many years, the heart possesses an incredible capacity to pave side streets, to grow and expand smaller pre-existing vessels, or even generate new ones, a process called angiogenesis, that effectively bypass the primary blockage. These collateral vessels act as natural detours, providing alternative routes for blood flow to reach the myocardial tissue beyond the obstructed artery. This explains why, quite often, a 70-year-old individual might survive a significant heart attack that would prove instantly fatal to a 40-year-old, the older heart having endured decades of progressive atherosclerosis had sufficient time to gradually develop and strengthen these vital collateral pathways, offering a lifeline when the main artery fails. In contrast, in a younger person experiencing a sudden plaque rupture and complete occlusion, the highway abruptly shuts down. And because there has not been enough time for these detours to develop, there is often no alternative route for blood to reach the endangered heart muscle, leading to more extensive and rapid tissue death. One of the most effective and proactive ways to stimulate the growth and development of these crucial collateral vessels is through consistent physical exercise, particularly targeted forms like Zone 2 training and high-intensity interval training, HIIT. Engaging in regular, moderate-intensity aerobic exercise, Zone 2, over time promotes sustained shear stress on the arterial walls, a known stimulus for angiogenesis, the formation of new blood vessels, and the expansion of existing collaterals. HIIT, with its alternating periods of intense exertion and recovery, also places unique and powerful demands on the cardiovascular system that can encourage vascular adaptation and remodeling. Exercise, therefore, acts as a powerful biological architect, constructing and strengthening this vital network of backup vessels that literally buys you time in the event of a coronary event. And in the critical context of a heart attack, time is truly the only currency that matters. In the emergency room, the adage, "time is muscle," is constantly reiterated with grim urgency. Every minute counts. After approximately 20 minutes of severe ischemia, lack of blood flow, irreversible damage to heart muscle cells begins. After about 90 minutes of complete occlusion, significant portions of heart tissue can turn into non-contractile scar tissue. Crucially, scar tissue cannot pump blood, leading to permanent impairment of cardiac function and a diminished quality of life. To preserve as much viable heart muscle as possible, prompt recognition of symptoms and immediate medical intervention are paramount. The presentation of heart attack symptoms can vary significantly, often along gender lines, leading to critical delays in seeking care and tragically poorer outcomes, especially for women. Men typically experience what is often portrayed as the Hollywood heart attack. Classic symptoms, such as crushing chest pressure or pain, which may radiate down the left arm, into the jaw or back. These symptoms are often intense and unmistakable. For women, however, the symptoms are frequently more insidious, subtle, and often atypical, making them easier to misinterpret or dismiss as less serious conditions like anxiety, indigestion, or flu. These can include extreme fatigue that is out of proportion to exertion, persistent shortness of breath even at rest, unexplained dizziness or lightheadedness, nausea, vomiting, unusual pain in the back, neck, or jaw, or even intense acid reflux like discomfort that doesn't respond to antacids. A sudden and inexplicable sense of impending doom or dread is also a symptom that should never be ignored by anyone, regardless of gender. If you or someone you know experiences any of these warning signs, particularly if they are new, severe, persistent, or accompanied by an unusual feeling of unease, immediate emergency medical attention is absolutely vital. Do not hesitate. Time saved is heart muscle saved. When the critical plumbing of the heart's arteries fails due to a significant blockage, interventional cardiologists are prepared to perform life-saving procedures. One of the most common and effective interventions is a percutaneous coronary intervention, PCI, often referred to as an angioplasty with stenting. During this procedure, a specialized, thin, flexible tube, catheter, is carefully threaded through an access point typically in the wrist, radial artery, or groin, femoral artery, and guided up to the heart. Using a special contrast dye that is visible under X-ray, the cardiologist precisely locates the site of the blockage, or jam. A tiny balloon at the tip of the catheter is then inflated, effectively smashing the plaque against the arterial wall and widening the narrowed vessel, restoring initial blood flow. Immediately following this, a stent, a tiny, expandable metal mesh scaffold, is deployed. This stent acts as a permanent internal scaffold, holding the artery open, preventing it from collapsing, and significantly reducing the risk of re-narrowing, thus restoring optimal and sustained blood flow to the heart muscle. In cases of very extensive or complex blockages, coronary artery bypass graft, CABG, surgery may be required, where healthy blood vessels from other parts of the body are used to create new routes around the blocked coronary arteries. The ultimate goal, however, is not merely to fix the plumbing after it has failed, but rather to identify the fire before the house burns down. This necessitates a proactive screening strategy that goes far beyond conventional methods. Standard blood work, while undoubtedly valuable for assessing traditional cardiovascular risk factors like cholesterol and blood sugar levels, only provides a snapshot of the ingredients circulating in your bloodstream. It cannot tell you whether these ingredients are actively sticking to the walls of your arteries and forming dangerous plaques. For truly early and effective detection of silent coronary artery disease, you need more advanced, direct imaging data that visualizes the arteries themselves. The first crucial screening tool to consider is the coronary artery calcium (CAC) score. This is a quick, non-invasive, and low-radiation 5-minute computed tomography (CT) scan of the heart that precisely measures the amount of calcified, hardened plaque within your coronary arteries. Calcium is a component of stable, mature atherosclerotic plaque, and its presence is a direct indicator of coronary artery disease burden. A CAC score of 0 is considered ideal, indicating a very low likelihood of significant coronary artery disease and a reassuringly low future risk of cardiac events. Conversely, a score exceeding 400 signifies a substantial plaque burden and indicates a significant risk, often described by clinicians as a ticking time bomb. While the CAC score is excellent for detecting hardened, stable plaque, it has a limitation. It does not visualize the more dangerous soft plaques, the invisible, unstable blisters of lipid-rich material that have not yet undergone significant calcification. For this, the next level of screening is the CT angiogram, CCTA. This advanced imaging technique uses intravenous contrast dye to provide a detailed, three-dimensional view of your coronary arteries, allowing physicians to directly visualize both calcified and non-calcified soft plaque, assess the exact degree of narrowing, and crucially, identify vulnerable lesions that are prone to rupture. The CT angiogram is increasingly recognized by leading experts as the ultimate early warning system, capable of detecting these hidden, unstable plaques long before they lead to symptoms or a catastrophic event. These tools empower individuals and their healthcare providers to intervene proactively. Ultimately, the tragedy of the healthy heart attack is almost invariably a tragedy born of ignorance, a profound lack of awareness about the silent progression of cardiovascular disease and the advanced diagnostic tools available for early detection. The power to prevent these devastating events lies firmly in our hands, through a combination of consistent lifestyle modifications and informed medical vigilance. Proactive management of blood pressure is paramount to prevent the continuous mechanical tearing and damage to your arterial walls that initiates plaque formation. Diligent control of blood sugar levels is essential to curb inflammation and minimize the factors that accelerate plaque formation and progression. And crucially, consistent physical activity, as discussed, not only improves overall cardiovascular health, but also encourages the development of vital collateral circulation, building a robust internal backup system. Do not make dangerous assumptions about your internal health based solely on outward appearances or how you feel on any given day. Leverage the incredible diagnostic technologies and medical knowledge we possess today. Empower yourself with information. Engage in proactive screening when appropriate, and take decisive steps to protect your heart before it's too late. The future of your heart health, and indeed your life, depends on knowing, not guessing.